Imagine for a second being an asthma patient back in the 1970s. You feel that terrifying tightness in your chest, right? The struggle to just pull air in,
Oh, it's an incredibly scary feeling.
right? So you grab your trusted rescue inhaler, you take a puff, and within minutes, your airways open up. You feel cured.
Yeah, you feel like the crisis is over.
Exactly. But what you don't realize, and what even your doctor doesn't realize at the time, is that the very medication making you feel better is it's quietly masking a fatal condition that's just building up inside your lungs.
It is a genuinely harrowing chapter in medical history because, when we treat only the symptoms we can easily observe while just completely ignoring the underlying invisible mechanisms, well, the consequences for patients can be catastrophic.
Yeah, catastrophic is the right word.
Okay.
So today we are taking a deep dive into the true mechanics of asthma. We are pulling from clinical nursing texts, medical history, and the latest pathophysiological research to figure this out.
It's a lot of ground to cover, but it's so important.
It really is. Whether you are prepping for a clinical exam, maybe trying to understand your own diagnosis, or you're just intensely curious about the human body, we are going to completely flip the script on what you think you know about bronchospasm, acute management, and, that famous blue rescue inhaler.
Because the story of asthma, it isn't just a straightforward medical timeline. It's really a story of how a fundamental misunderstanding of human biology shaped treatment for over a century, and how finally unlearning that misconception completely rewrote modern medicine.
Yeah, the unlearning part is wild. Our mission today is to uncover how a 19th century misunderstanding caused a modern medical crisis, and to decode what is truly happening on a cellular level inside the lungs during an acute attack.
I'm ready when you are.
Okay, let's unpack this. To understand the modern nursing approach to asthma, we have to look at how incredibly wrong we were for most of medical history.
Yeah.
Like, where does our understanding of this condition even begin?
Well, it goes back remarkably far, actually. The word asthma itself is ancient. It comes from the Greek word azein, which translates roughly to panting or, breathing with an open mouth.
Canting, that makes sense, yeah.
Right. You see it show up in the medical texts of Hippocrates around 450 BC, but there is a critical distinction in how they viewed it back then.
What?
Hippocrates used the term strictly to describe a symptom. He was describing the state of being breathless, not a distinct standalone disease.
Oh, I see. So it was just a clinical observation, sort of like a physician today is saying a patient has a fever or a cough. It tells you what is happening, but it doesn't really tell you why it's happening.
Precisely, yeah. The shift toward recognizing it as a specific mechanical condition that started later. In the 2nd century AD, there was a Greek physician named Aretaeus of Cappadocia,
Okay.
and he provided one of the first truly detailed clinical descriptions of an attack. He noticed a very specific, terrifying hallmark of asthma. The primary difficulty for the patient wasn't actually getting air in. The struggle was breathing out.
Wow. Which is such a counterintuitive detail if you aren't living it, right? Or if you aren't
Yeah,
treating
I
it
know.
clinically. You think of suffocating as not being able to draw breath into your lungs, but asthma actually traps the exhausted air inside.
Yeah, it's air trapping. It's horrible.
And just reading through the source material, it's fascinating how physicians were picking up on environmental clues centuries before they even had a word for allergen. Like there's that incredible case study from the 12th century involving Moses Maimonides.
Oh, yes. Maimonides was treating a patient who was widely believed to be the son of Sultan Saladin. He wrote an entire medical treatise on asthma specifically for this young man.
Just for him. Wow.
Yeah, and his recommendations included dietary changes, relocating to find clean air, and avoiding damp climates. So he had an intuitive, practical grasp of environmental triggers long before the concept of the immune system was even established.
That's brilliant for the 12th century. And then if you jump forward to like 1698, we get Sir John Floyer, an English physician who actually suffered from asthma himself.
Yes, the self-observation era.
Right. He kept these meticulous diaries of his own attacks and realized they followed a diurnal pattern, meaning his symptoms were consistently worse at night. So he was essentially performing early trigger identification on himself. But all of this observational progress hits a massive roadblock in 1860, doesn't it? This is the turning point that set us on the wrong path for over a century.
It really is. So in 1860, a physician named Henry Hyde Salter published a highly influential book defining asthma fundamentally as a disease of bronchial muscular spasm.
Just the muscles.
Right. He proposed this idea of nervous bronchoconstriction. And, I mean, to be fair to him, based on the tools he had at the time, it made sense. The airways were constricting, so the muscles wrapping around them must be the problem.
Sure, you see a pipe squeezing shut, you blame the clamp.
Exactly. And for over 100 years, that became the gospel truth in medicine. Asthma was viewed operationally as just a muscle problem. The airway muscles were just twitchy and irritable.
And naturally, if you believe the root cause of a disease is just a muscle spasm, well, your entire treatment protocol is going to be focused on forcing that muscle to relax.
That was the logic, yeah. Bronchodilators, which are medications designed specifically to relax smooth muscle, they were considered both the diagnostic tool and the cure. That muscle-centric model completely dominated the field until the late 1980s and early 1990s.
Which is when researchers like Stephen Holgate and Peter Barnes in the UK started looking at actual bronchial biopsies, right?
Yes, and what they found under the microscope completely shattered that 1860 model.
What did they see?
Well, they looked at patients who had very mild asthma, patients who were perfectly well controlled and had zero symptoms at the exact time of the biopsy. But when they looked at the tissue, their airways showed persistent, active eosinophilic inflammation and thickening of the airway wall.
Wow. So even when they felt fine, their lungs were inflamed.
Exactly. It was a massive paradigm shift. It forced the medical community to basically reclassify asthma from the ground up. The underlying pathology wasn't a muscle disease at all. It was fundamentally a chronic inflammatory disease. And the bronchospasm, that twitchy muscle, was just a downstream symptom of that persistent inflammation.
I have to admit, I was so surprised reading this. I mean, for over a century, the medical consensus was essentially just twitchy muscles. So we were basically treating a chronic smoldering fire in the lungs as if it was just a faulty smoke detector going off.
That is the perfect analogy, and that exact redefinition from a muscle problem to an inflammatory disease where the bronchospasm is just the alarm bell ringing, completely revolutionized modern acute management.
Changes everything about how you treat it.
It really does. It's the reason why the Global Initiative for Asthma, or GINO, rewrote global treatment algorithms in 1993, firmly shifting the primary focus to inhaled corticosteroids as the necessary daily controller therapy to, actually put out the fire.
So if asthma is actually this smoldering inflammatory fire masquerading as a muscle problem, we need to break down exactly what happens in the airway to cause an attack. The nursing texts describe this as a mismatch between airway tone and what the airway should be doing. Let's look at the actual physiological timeline here.
Let's do that. So, in a healthy person, the smooth muscle wrapping around the bronchi, which are the tubes carrying air into your lungs, maintains a baseline tone.
A normal level of tension.
Right. If you inhale a mild irritant, that muscle might constrict modestly to protect the deeper lungs, and then it just relaxes. But in an asthmatic airway, you have a dysfunctional cascade that happens in distinct overlapping layers. The first layer is the immediate reaction, bronchospasm.
The fast component.
Yes, the fast component.
Yeah.
The airway smooth muscle contracts aggressively and excessively in response to a trigger. That could be cold air, pollen, exercise, you name it. It physically narrows the airway lumen, which is the central space the air flows through. This is the fast, reversible component of an attack.
And if you were holding a little blue rescue inhaler right now, this is exactly what it is designed to fix. When you take a short-acting beta-2 agonist like albuterol, it goes to work in minutes. But I want to pause here because the mechanism is fascinating.
Oh, it really is.
The sources say it binds to beta-2 adrenergic receptors on the smooth muscle, which raises intracellular cyclic AMP or CAMP. Can we break that down? What is CAMP actually doing in there?
Sure. Think of CAMP as an internal cellular messenger. When the albuterol molecule docks onto the receptor on the outside of the muscle cell, it triggers the production of CAMP inside the cell.
Okay, so it sends a signal inward.
Right. And that CAMP messenger basically runs through the cell shouting, "Relax, stand down." It chemically interrupts the contraction process, forcing the muscle to loosen its grip on the airway.
The pipe is unclogged, and the patient can breathe again. But here's where it gets really interesting. That muscle spasm is just the outer layer, right? The second layer of this condition is the inflammation itself.
Exactly. This is the slow, silent component. Let's look at the most common type, the allergic phenotype of asthma, which is often called type 2 high. When you are exposed to an allergen, your immune system overreacts. It activates specific immune cells called T helper 2 cells.
Okay, the T cells wake up.
Yeah. And these cells sound a biochemical alarm by releasing a flood of messenger proteins called cytokines, specifically interleukin-4, interleukin-5, and interleukin-13.
Wait, interleukins are those the actual signals calling for backup?
Exactly. They're basically chemical text messages sent to the rest of the immune system. And the specific backup they call in are eosinophils.
Eosinophils, okay.
Yeah, eosinophils are a type of white blood cell designed to fight off massive threats like parasites. They are packed with toxic granules. But in asthma, they arrive in the airway and release those toxins unnecessarily, causing immense collateral damage to your own lung tissue.
Man, so the body is essentially carpet bombing its own airways just to fight off pollen. And the sources note these cytokines also stimulate B cells to produce IgE antibodies, which prime the body to overreact even faster next time.
Yes, it creates a vicious cycle of sensitivity.
Plus, they send the mucus glands into overdrive, creating thick, sticky mucus that physically plugs up the smaller airways.
And you cannot undo that complex immune cascade in 3 minutes with a puff of albuterol. You just can't. You need an entirely different class of medication, inhaled corticosteroids, taken every single day as a controller to penetrate the tissue and tell those T cells and eosinophils to stand down. What's fascinating here is the stark contrast in speed and feedback.
How so?
Well, you have a patient experiencing instant life-saving relief from the rescue inhaler, right? While the controller medication operates invisibly on a cellular level over days and weeks with absolutely no immediate sensory payoff.
Right, you don't feel a steroid working instantly.
Yeah.
That disconnect between how a medication feels and what the disease is actually doing is crucial, especially because it leads right into the third layer of this condition, which is airway remodeling.
The permanent consequence.
Yeah. If a patient just uses the fast rescue inhaler to feel better today and ignores the slow inflammation, years of that unchecked immune carpet bombing will permanently damage the architecture of the lung.
It leads to severe structural changes. The smooth muscle we talked about hypertrophies.
Which means it bulks up, right? Like a bodybuilder.
Yes, exactly.
Yeah.
The muscle cells literally enlarge and multiply from the constant working and spasming, making the airway permanently thicker and narrower. Additionally, the basement membrane, which is the foundational layer of connective tissue that the airway lining sits on, becomes thick and stiff. Blood vessels in the airway walls proliferate and become engorged.
So the airflow obstruction slowly becomes less and less reversible over time. Using that daily controller inhaler isn't just about reducing symptoms this week. It is about preventing permanent architectural scarring of your lungs over a lifetime.
And if we don't effectively communicate the difference between the fast spasms and the slow inflammation to patients, the results can be fatal.
Which transitions us to the most sobering part of our deep dive. We have concrete historical examples of what happens when the medical field gets this balance wrong. Let's talk about the phenobarbital story in New Zealand in the 1970s and 80s.
It remains a deeply tragic public health lesson. During that period, an epidemiologist named Neil Pearce and his colleagues began documenting a sharp, highly alarming spike in asthma-related deaths across New Zealand.
A sudden spike, out of nowhere.
Pretty much. And after rigorous investigation, they traced the mortality spike back to the introduction and heavy marketing of a specific drug called phenobarbital,
Which was a very potent, short-acting rescue inhaler, a powerful bronchodilator.
a massively powerful one. Patients and physicians were using this bronchodilator as their primary and often sole treatment. The medication was so remarkably good at forcing the airway muscles to relax that patients felt completely fine.
They thought they were cured.
Yeah, they felt their asthma was controlled. But the underlying eosinophilic inflammation was completely unmedicated. It was quietly worsening every single day. They were masking the disease, attack after attack, until the inflammation became so severe and the mucus plugging so dense that the inhaler could no longer force the airway open, resulting in fatal attacks.
It's horrifying. They were using a chemical crowbar to hold the door open while the house burned down. And when phenobarbital was heavily restricted, the death rate plummeted back down, right?
Almost immediately, yes.
But what's truly wild is that the exact same phenomenon had already happened in the United Kingdom in the 1960s with a different high-dose beta agonist called isoprotronol.
Exactly. The medical field simply didn't institutionalize the lesson the first time around.
Imagine the psychological terror of that for a patient. You reach for the very medication designed to save you, the one that has always worked in minutes, only to find out it's actively masking a fatal condition. How did the broader medical community miss the inflammation piece for so long when people were actively dying?
It ultimately comes down to a behavioral trap created by human nature and pharmacology. Because the rescue inhaler feels like a cure, It provides this undeniable instant relief from a terrifying sensation of suffocation. It creates an incredibly powerful behavioral feedback loop.
Cause and effect.
Yeah.
I take this, I feel better.
Right. Patients naturally over-relied on the bronchodilator because they could physically feel it working. Conversely, they ignored the inhaled corticosteroids because taking them felt like breathing regular air. The medical community missed it because for a long time they were looking at symptom relief, the relaxed muscle, as the ultimate endpoint of treatment, rather than disease control.
And remarkably, we had to learn this lesson again as recently as 2003 with the SMART trial, the salmeterol multi-center asthma research trial. They were studying salmeterol, which is a long-acting beta agonist, or LAB.
Right.
It works like albuterol, but it keeps the muscle relaxed for 12 hours. But the trial revealed a real statistically significant increase in asthma-related deaths and life-threatening experiences when patients took it without a background corticosteroid.
They actually had to halt the trial early because the safety signal was so dangerously clear. It forced the FDA to issue a strict boxed warning, mandating that LABAs can never be prescribed as a monotherapy for asthma. They must always, without exception, be paired with an inhaled corticosteroid to treat the inflammation simultaneously.
So we've explored the internal mechanics of the disease, and we know how dangerous mismanagement can be. Let's look outside the body for a moment. What actually kicks off this inflammatory cascade in the real world? Because environmental triggers can be terrifyingly unpredictable. The sources highlight the thunderstorm asthma event in Melbourne, Australia in November 2016.
That event is a staggering demonstration of how the environment interacts with human physiology. It was peak grass pollen season. A severe thunderstorm rolled into Melbourne, bringing massive updrafts, gusty winds, a sudden plunge in temperature, and a dramatic increase in atmospheric moisture.
And that moisture is the key, right? Because normally, intact ryegrass pollen grains are relatively large. If you inhale them, they just get trapped in the mucosal lining of your nose, which causes standard hay fever. But how do they end up deep in people's lungs?
It was caused by a fascinating physical process called osmotic shock.
Osmotic shock.
Yeah, when that sudden storm hit, the intense humidity caused those large pollen grains to rapidly absorb water. They swelled up until they literally burst open, shattering into thousands of microscopic allergenic fragments.
Oh, wow. And then the storm's downdrafts swept those microparticles back down to street level. Because they were now so microscopically small, they completely bypassed the body's upper airway defense mechanisms. They penetrated deep into the lower airways of almost anyone who was outside.
It was immediate. Within a matter of hours, emergency departments across the entire city of Melbourne were completely overwhelmed.
Thousands of people were suddenly in severe respiratory distress. And this is the most alarming part. Many of these people had absolutely no prior asthma diagnosis.
Exactly. They had no idea.
They thought they only suffered from seasonal hay fever. A routine thunderstorm triggered a mass casualty event, and multiple people tragically lost their lives.
If we connect this to the bigger picture, the Melbourne event isn't just an isolated freak occurrence. It is a profound warning about climate change. The data shows we are seeing longer and vastly more intense pollen seasons. We are seeing altered, more volatile storm patterns capable of creating these exact thunderstorm asthma events, and we are seeing exponentially more frequent wildfire smoke events.
And it is crucial to note from the sources that this environmental burden isn't shared equally. Urban, lower-income, and minority populations bear a disproportionately higher rate of severe asthma and hospitalization. It's intrinsically tied to higher baseline air pollution, poor housing conditions that harbor mold and pests, and deeply unequal access to those vital daily controller medications.
It is a profound environmental justice issue. The environment physically shapes the prevalence of the disease. We also see this broad environmental concept in the ongoing medical debate around the hygiene hypothesis, which was first proposed by epidemiologist David Strachan back in 1989.
Right, his famous BMJ paper.
Yeah.
He noticed a fascinating correlation, didn't he? Children who grew up with a lot of older siblings generally had much lower rates of hay fever and allergic asthma.
His initial theory was that smaller families and increasingly hygienic, sanitized modern environments severely reduced childhood exposure to everyday infections. Without those early microbial challenges, the developing immune system remains undertrained and bored, essentially.
Bored immune cells.
Yeah, so it defaults to a type 2 skewed allergic response, attacking harmless things like pollen or dust mites just for something to do.
Though the modern scientific nuance has shifted a bit, right? It's less about needing to roll around in dirt to catch infections and more about the microbiome. The old friends framing the idea that our immune systems evolved alongside diverse, non-pathogenic microbes, and we need exposure to them early in life to properly calibrate our immune responses.
Exactly. While the exact mechanisms are still heavily researched and debated, it remains a crucial framework for understanding why allergic diseases have skyrocketed so sharply in industrialized nations over the last century.
Okay, let's zoom back into the clinical setting. Because if you are a nursing student learning this, a practitioner, or just someone managing this disease at home, there are some incredibly dangerous myths we need to clear up based on our sources.
Oh, absolutely.
Let's start with misconception number 1, the silent chest. Imagine you're observing a patient having a severe asthma attack. They're wheezing loudly, struggling to breathe, and then suddenly the wheezing stops. Their chest is completely quiet.
And basic human instinct says, quiet is good. The wheezing stopped, so the medication must be working, and they are getting better. In reality, a silent chest during an acute attack is a catastrophic medical emergency.
Why? What is actually happening in the airway?
It means the airflow obstruction has become so profound, the airway is so incredibly tight and plugged with mucus that there isn't even enough air moving back and forth to generate the sound of a wheeze. The silence doesn't mean the airway is open, it means the airway is entirely closed.
It's chilling. A lack of noise literally means a lack of air. Misconception 2, the idea that kids fully outgrow asthma.
It is true that many children enter a state of clinical remission by adolescence and they stop experiencing any day-to-day symptoms. But longitudinal studies show that subclinical hyperresponsiveness, that underlying invisible immune sensitivity in the airway tissue, can quietly persist into adulthood.
Just waiting.
Exactly. And it can roar back to life decades later, often triggered by a new environmental exposure or a severe respiratory viral infection.
Which brings us to the cutting edge of how we treat this today. We've talked a lot about the allergic immune response, but asthma is no longer considered one disease. So what does this all mean for the future of treatment?
It means we have to treat asthma as an umbrella term. In modern medicine, we differentiate between what a disease looks like on the outside, its phenotype, like wheezing and coughing, and the actual biological mechanism causing it on the inside, which is the endotype. We now know there are multiple distinct endotypes hiding under the asthma umbrella.
Right, so you have the allergic type 2 high asthma we've discussed, which is driven by eosinophils. But the sources also detail type 2 low asthma. This is driven by an entirely different white blood cell called a neutrophil, which is typically a general infection fighter.
Right.
And importantly, neutrophilic asthma responds very poorly to standard inhaled corticosteroids.
And this realization that we are dealing with different cellular drivers led to the development of biologic drugs. Instead of just throwing a general blanket anti-inflammatory steroid at the lungs, we can use monoclonal antibodies. These are highly specific, lab-engineered proteins.
How do they work compared to a steroid?
Rather than reducing overall inflammation, biologics act like molecular sponges or interceptors. Take a drug like omalizumab, which specifically hunts down and neutralizes IgE antibodies before they can trigger an allergic response.
Oh, wow.
Or drugs like mepolizumab, benralizumab, and dupilumab. They specifically target those cytokine text messages we talked about earlier, interleukin-5 and interleukin-4 and 13. They intercept the message before the eosinophils even get the call to attack.
This raises the bar for how precise medicine can be. We are stopping the cellular domino effect before the first piece even falls.
This raises an important question for the future of respiratory medicine as well. If asthma is an umbrella, we have to be incredibly precise in how we diagnose it compared to other conditions. For instance, comparing asthma to COPD, chronic obstructive pulmonary disease.
Right, because they both cause severe airflow obstruction.
They do. But asthma is classically defined by its reversibility, whereas COPD involves a largely fixed, permanent obstruction and alveolar destruction, usually resulting from long-term smoking.
Yet, while they are different diseases, the treatments sometimes overlap in fascinating ways. Speaking of unexpected overlaps, I have to mention the COVID-19 connection from the pathophysiological research.
Oh, the StudyGuide study.
Yeah. During the height of the pandemic, researchers ran the StudyGuide study in Oxford. They found that inhaled budesonide, which is a standard everyday asthma controller medication, actually reduced the likelihood of patients needing urgent care for COVID-19 if it was administered early in the infection.
It perfectly highlights how deeply interconnected our immune pathways are. A century-old asthma drug class crossing over to suppress the inflammatory cascade of a novel virus. It shows that when you understand the underlying mechanism of inflammation, you can find surprising benefits across entirely different diseases.
So to pull all of this together for you listening, We have journeyed from ancient Greek physicians observing patients panting in the Mediterranean through the completely avoidable tragedy of the phenotyral crisis in New Zealand to the microscopic ryegrass pollen shattering from osmotic shock in a Melbourne thunderstorm. And the undeniable life-saving through line of all this research is this asthma is fundamentally a chronic inflammatory disease, not just a simple muscle spasm.
And understanding that vital distinction isn't just academic trivia for a textbook.
No, absolutely not. Whether you are prepping for a nursing exam, managing your own inhaler at home, or you are just deeply curious about human physiology, understanding the why behind the rescue inhaler versus the controller medication could literally save a life, especially if it helps you recognize the terrifying reality of the silent chest.
It truly is a triumph of modern medicine that we've decoded these underlying cellular pathways. But it leaves us with a fascinating, slightly unsettling thought to mull over.
Let's hear it.
If asthma, one of the most common, seemingly straightforward diseases in human history, turned out to be an umbrella term for several entirely different immune dysfunctions, just masquerading behind a shared symptom, how many other common diseases that we treat as a single illness today are actually just shared symptoms hiding completely different conditions?
It makes you wonder how many other simple plumbing issues in medicine are actually complex, smoldering fires just waiting for us to finally notice the smoke.